Hi, everybody. We're going to go over joint June. This week, we're talking about the knee joint. Uh, so let's get into it. We're just taking a little different approach from our Muscle Monday. Just let's look at some different stuff, go into a little bit more depth, and we'll see what shakes out. So let's talk about the knee joint. Well, what is the knee joint? Well, what does it do? Well, the function of it, of course, is that it flexes and extends the leg. So it's going to obviously be a weight-bearing joint, and it is major for shock absorption. In fact, whenever you're doing sprinting, the knee joint handles the negative forces, the eccentric forces. It keeps you from falling on your face. Obviously, it's working in weight bearing. It does have a lot to do with stabilization. You know, it's the middle between two long bones. So there's going to be some instability there. It does rotate, which a lot of people don't think about. There's this thing called the screw home mechanism. So while we often will call this has led to in anatomy some arguments going on about, hey, is the knee joint actually a single axis joint? And a lot of people call it 1+ because it has the screw home mechanism. So some facts about it. Well, it's complex. It's really two joints. So it's our tibiofemoral and our patellofemoral joints that act together to cause the movement that we normally have. So then we're going to have we got to have some balance in the strength for weight bearing. You know, if we're all just quads or all just hamstrings, that means bad things can happen on the other side of the joint. So we have to have balance anterior and posteriorly, and actually in medially and laterally, and in the rotation as well. And it's one of the most common places for athletic injuries. I mean, shoot, if you just go out walking down the street, how many people do you see, older people with a knee brace on? It happens more and more. So it really is not only just for athletic injuries, but it's an area that tends to cause people problems. Now, the bones. What are the bones? Well, it's the femur, the tibia, and the patella, which is the kneecap, right? So we see our femur, it's the big bone up here. We have our tibia down here. Now, some people will say, hey, the fibula. Hey, why aren't we talking about that? It ain't part of the knee joint, guys. It is a non-weight bearing joint. It is the tib-fib joint, tibial-fibular joint. It's not part of the knee. And then, of course, we have our patella, which is a sesamoid bone, right? It is entrapped into the tendon there. So we know that we have some agonists and antagonists. Remember, agonists are the ones that do the action. Antagonists are the counters to that. So really, these could be agonists for either one. These would be agonists for extension and the agonist for flexion. So for extension, okay, the sartorius to some extent, but then we have our quad muscles. Our rectus femoris, vastus medialis, vastus intermedius, and vastus lateralis. Three of which only cross the knee and only cause knee extension, and the rec fem is that special child that starts at the hip. So it is a hip flexor and knee flexor, knee extensor, excuse me. And then we have our antagonists, which are the semimembranosus, semitendinosus, and biceps femoris. Both the long head and the short head are flexors here. So let's take a look at these muscles in case you've never seen them before. So here's our sartorius. So it's often called the Taylor's muscle due to its length. And then we see the rectus femoris, our vastus lateralis, and our vastus medialis. Now, you might say, hey, wait a second, Dr. Mann, you said there were 3 vasti. Yeah, you're right. There's the vastus intermedius. It lies deep to rec fem. We just can't see it. Now, if we look at the posterior side, we could see, there's a lot more listed on here. The biceps femoris is our lateral set of muscles, and our semitendinosus and membranosus are medial, with the semitendinosus being the one on top, T-top. Now, if we look at some of the ligaments here, we know we've got, these are ligaments I'm sure everybody's heard of. I know everybody has heard of the ACL. That's that really bad one that is constantly torn, especially in women's sport. Its counter is the posterior cruciate ligament. Now, this prevents anterior displacement of the femur, posterior displacement of the tibia. It keeps the tibia from moving backwards in relation to the femur, where the ACL does the opposite. Then we have our LCLs and MCLs. Now, our lateral and medial collateral ligaments. Well, the lateral collateral ligament is obviously on the lateral side, on the outside. Medial collateral is on the inside. Now, these two ligaments prevent the medial collateral prevents excessive lateral movement of the lower leg, so internal movement of the thigh. And then the lateral collateral does the opposite. It prevents excessive outward movement. So the lateral of the thigh, the abduction of the tibia. Then our patellar tendon, no, our patellar tendon, yeah, that is our patellar tendon. Sometimes called patellar ligament. It is it basically our patellar tendon. It works with our patella to help the force by the quads. We could go into a lot of stuff and for a long time about the patella, but let me tell you this: it's not just to protect your knee. If it were, then we would have a lot more sesamoid bones. Okay, so we just talked about some of these ligaments. Let's take a look here. We can see our anterior cruciate ligament, and what do you guess is behind that? Well, that's our PCL. And we can see our lateral collateral ligament over here and our medial collateral ligament right here. And then you're like, hey, Dr. Mann, you just talked about the patellar tendon. Where is it? Well, it's cut away, right? So you can see everything else. But it would insert down here into the tibial tuberosity, and obviously it starts up here in the quad. Now, we also have some other tissues, our menisci, our fat pads, and our bursa. Now, what these do is they help to reduce friction and reduce force. So let's just take a look. Well, let's talk about it here before we go into it. Now, the menisci basically deepen the socket to allow what is a flat tibial plateau to have a little bit of depth, so it provides some stability. Now, the fat pads, these are shock absorbers as well, and they help to distribute pressure and reduce load. The fat pads, the best way that I can, show you, like, where's a fat pad at? Well, if you go ahead and you flex your knee really hard, the stuff that's sticking out on either side isn't a bursa, even though that's what people will often tell you. That's your fat pad. So it helps to distribute the pressure, reduce the load, and help with reduce friction. And then the bursa, obviously, it's a fluid-filled sac, and that's what it does, is it reduces friction. We'll have suprapatellar, prepatellar, infrapatellar. We got bursa all over the place. Now let's go ahead and let's take a look at just at least these menisci and the fat pads. And we can see that our menisci are here in these two C shape. This one's more of a circle, and this one's more of a C. We can see that we've got this shape here that obviously deepens it out. That at the bottom, well, that is the articular cartilage and the tibial plateau right there, as you can see whenever it's cut away. Now, some common injuries, of course, ACL, MCL, meniscus, PCL, tear. We've got all the tears. LCL, it's like, how come LCL isn't listed on here? Can it get torn? Yeah, but it takes a lot for an LCL tear. Pretty common though is patellar tendinopathy, jumper's knee, which is just that's what it is. It's a tendinopathy. You've got an inflammation in the tendon. It's a condition of inflammation that's staying there all the time. And then patellofemoral syndrome is runner's knee. And this is just something that happens as a result of poor mechanics. Really, both of them are. And we could talk about those in greater detail in the future sometime if that's something that you all are interested in. So to maintain the knee, if you want to have a good knee throughout your life, what do you need to do? Well, one, don't hurt yourself. I guess don't play basketball, and if you're in soccer, if you're a woman. No, I'm kidding. But those do have 10% incidence rates. But hey, we need to strengthen the muscles around the knee for some. Okay, so the quads, the hamstrings a little bit. Hey, our glutes, our abductors are actually crucial, even though it's not listed in here. And then our calves. It's like calves. Yeah, the gastrocs actually knee flexor. It's not listed on here. It's minor, but there's a whole story that if you end up coming here that you'll hear about it. Mobility. Well, we need to make sure that we have appropriate range of motion, that we have good hip extension, external rotation. And to be honest with you, internal rotation is absolutely vital to appropriate knee health. Now, I hear some people saying, "Whoa, but if you have too internal rotation, that could recreate the mechanism." Yeah, that internal rotation that's happening as a part of gait is going to occur from some way or another. So if you're not getting it from your hip, it's coming more from the ankle and the knee anyway. Um, Make sure that we have appropriate dorsiflexion so that we don't have to have more come from the knee, because if you can't flex from the ankle, there's more coming from the knee. If we foam roll, we can maybe reduce some tension there in that joint, especially pre-training. We need to make sure that we have controlled movement quality. And what does this mean? Dude, it means have good technique. Don't just keep loading things up just because you can. Load them up because it looks good and it provides a greater stimulus. Let's not let our ego get in the way here. And then, dude, warming up, the dynamic warm ups, doing the appropriate ranges of motion to make sure that that joint is moving the way that it needs to move and everything's moving the way that it needs to move. Hey, if you enjoy information like this, as always, come join us in Aggie Land. Hope to see you again soon for a Joint June.